Hi, everyone, and welcome to episode 134 of the Veterinary Behaviour Chat podcast. And today we're going to have a chat about another SSRI, and that is escitalopram. So we started with fluoxetine, then we did sertraline. We're going to be chatting about paroxetine, and I wanted to chat about escitalopram in this episode. So, why is it important to talk about these different SSRIs? And I think, as I've mentioned in some of the other episodes, it's really important to understand that SSRIs have one kind of common mechanism of action, which is the inhibition of that serotonin reuptake transporter, so SERT. So all SSRIs block the SERT, the serotonin reuptake transporter, in order to increase the concentration of serotonin in the synapse, right? So that is kind of the primary action, or the primary mechanism of action of all of the SSRIs. However, each individual SSRI potentially may have other activities that we need to be aware of, because that might inform our choices when it comes to choosing one over the other, which SSRI to start on, and so on. And so I thought we'd talk about escitalopram today, because I personally use escitalopram quite a bit. And I feel it's a really useful SSRI for many of those patients that are quite sensitive to the side effects that some of the other SSRIs might bring with them. So in particular, perhaps fluoxetine and maybe paroxetine, that can have those sort of quite flattening side effects, so can cause quite a lot of lethargy and depression, but also can cause this appetite suppression, which for some patients can be really quite unwanted and quite debilitating. And so escitalopram is also referred to as the quintessential SSRI, because really all it does is block the serotonin reuptake transporter. So it doesn't really have a whole load of other receptor activity, other receptors that it might target. So we know that, fluoxetine has quite a strong activity at the 5-HT2C receptor, that kind of activating piece. We spoke about sertraline and its dopaminergic effects. We spoke about paroxetine and those anticholinergic and very mild noradrenergic effects, right? So each of them has something else. And escitalopram is one of those, or is the SSRI that really doesn't do much else at all. So also known as the quintessential SSRI. So when would we use escitalopram perhaps over the others? And again, as I just mentioned, it seems to have the highest tolerability. So it's often used as a second line when other SSRIs have caused adverse effects. So I do know that some of my colleagues in the US in particular will go to escitalopram perhaps as a first line. Maybe if there is sort of fear and anxiety. So, we're almost using it a little bit for that sort of those very clean anxiolytic effects. But in other countries, especially where we have prescription cascades, such as in the UK, for example, and we have a licensed veterinary medication that is fluoxetine as an SSRI, then escitalopram might be our second choice if we are experiencing, extreme adverse effects. And that is a little bit the way in which I use it. So I will often, if I've used fluoxetine and I've quite liked the sort of the behavioral effects that it's had from a sort of an anxiolytic point of view, but it's had ongoing and persistent, perhaps appetite suppressing effects. So oftentimes fluoxetine might just suppress appetite for the first few weeks, and then that might lift. But I've had some patients where it's gone on to have sort of appetite altering effects for a much longer period of time. And that's then, when maybe we might think about changing to something that doesn't have that. So it's got a really high tolerability. So it's very well tolerated by many, many animals. And that's why it might be something to reach for if you're liking the effects of an SSRI, but we've got some adverse effects that we don't really want. So what about the doses of escitalopram? And here we actually have a really nice paper by Taylor et al. From 2017, looking at sort of the optimum dose ranges and looking at some of the other sort of pharmacodynamic and pharmacokinetic effects of escitalopram. And they came up with kind of the most effective dose that they found in that particular paper is 1.85 milligrams per kilogram per day. And that would oftentimes be split into either 2 or 3 doses. So depending on perhaps, your individual patient and how they metabolize the medication as an individual, you might need to give a 3 times a day dose. And I have a couple of patients that are on sort of every 8 hours of escitalopram. I would say most of them would be BID, so every 12 hours. Very rarely, I think, would I use escitalopram just once a day. But we would also always be kind of starting around that 1.85 mg per kg per day. So you calculate that total dose, and then you would split it into 2 or 3 administrations. So that's what's in the paper by Taylor et al. If you look in the Landsberg, Radosta Ackerman's book, Behavior Problems of the Dog and Cat from 2024, they have a dose range in there between 1 and 2.5 mg per kg, also probably per day. So they go a little bit higher. They go up to 2.5 milligrams per kilogram. So I think as long as you're kind of playing within that range, I think, that should be a pretty safe place to be. In terms of side effects, now we've already spoken about the fact that escitalopram has probably amongst the fewest side effects amongst the SSRIs. However, because of its activity at the 5-HT2A receptor, we can still get a little bit of lethargy, emotional flattening, cognitive slowing, and potentially some changes in sleep pattern. That would be sort of those 5-HT2A receptor effects. And we know 5-HT2A receptor is a really important receptor for all of the SSRIs. But again, it's thought of as having the highest tolerability and being kind of amongst the cleanest, if you like, SSRIs in terms of its receptor profile. What about contraindications? So when should we not be thinking about using escitalopram? And we don't really have a lot here. So obviously, if you have a patient that has either been on a monoamine oxidase inhibitor, so that would be selegiline in most of our veterinary patients. So if they've either been on a monoamine oxidase inhibitor, or if you're changing them from escitalopram to a monoamine oxidase inhibitor, we always want to have a 2-week washout period between those 2 medications. So remember, that's pretty much applies to all of the SSRIs. In fluoxetine, that washout period is even longer. And we might need to sort of consider using escitalopram concurrently with a non-steroidal anti-inflammatory medication. Again, that kind of goes for all of the SSRIs, right? We think that there may be an increased risk of bleeding if we're using SSRIs together with non-steroidals. However, in my practical experience and having listened to a number of lectures by also board-certified veterinary surgeons who maybe work very closely together with veterinary behavior specialists, they don't seem to really have any practical concern. So they don't, on their operating table, see any more bleeding in patients that are on an SSRI, and they're maybe giving a non-steroidal as part of their anesthetic regime, or they're giving a non-steroidal as part of their post-operative or even pre-operative kind of medication recommendations. So it's a theoretical risk, and we always need to be aware of it. But it's probably not a massive practical risk unless you've got a patient that maybe has, I don't know, a bleeding splenic tumor and is going, into a big surgery, or has had a big trauma and is going into surgery and is already bleeding. So that might be a time to think about, are they on an SSRI? Will they be getting a non-steroidal? What do we need to think about there? Do we need to not use the one or the other? So it's always something that we talk about. I think, there are some vets that are really quite kind of cautious about using SSRI together with non-steroidals. But I think if you speak to many, many vets and specialists that work with these medications a lot, then practically they deem the risk to be relatively low. And that, to be honest, is kind of all I have for you when it comes to escitalopram. So it absolutely is a really, really useful SSRI. I would use it quite frequently. Like I said, I would oftentimes maybe go to escitalopram if I had, a patient that with a strong diagnosis of fear, anxiety, and where other SSRIs were causing adverse effects. So yeah, I think it's a really useful medication. I think it's a medication not to be scared of. Yes, we have to be aware of the cascade, but as I've discussed with a number of colleagues recently, fluoxetine reconcile, so the veterinary formulation of fluoxetine, is actually only licensed for the use in separation anxiety in combination with a behavior modification plan. So as soon as you're using it not for that, you're already using it off-label. And so if you are then moving to another medication, unless you're moving to a tricyclic antidepressant, such as clomipramine, where we have Clomicalm, which is also only licensed for separation anxiety, apart from in Australia, where it's also licensed for urine marking in cats. But it's actually a very, very narrow diagnostic profile that we actually have a true license where we're using a baseline psychopharmaceutical on license, right? We have Pexion also where we're using it perhaps for noise events on license. I'm talking about long-acting medications now. But aside from separation anxiety, we don't really have, a very sort of clear diagnostic parameter. So as soon as we're using it for anything else, we're kind of going off-label anyway. So that maybe then makes that a little bit easier to justify moving to a different SSRI or a different medication. So that just as a little aside there. Okay, so this has been a relatively short episode, and that is because escitalopram really is exactly that, quintessential, quite the pure SSRI, if you like, from a mechanism of action. It's got that serotonin reuptake transporter blocking effect, but other than that, it doesn't really have any other big sort of neurotransmitter effects or anything massive to be too concerned about. So yeah, if you think you might have a patient that could benefit from escitalopram, give it a go. It's really not a scary SSRI to use at all. There's not that much, I guess, that you need to be afraid of or be worried about. So yeah, I think it's a really nice option, especially for some of our very sort of clean, fearful and anxious patients. All right. I hope you enjoyed this episode, and I look forward to seeing you next week for episode 135. Bye for now.